Good afternoon, everyone. I hope you can hear me loud and clear. My name is Pesingwerume. I'm a social accountability specialist with SAfAIDS based at the regional office in Harare. And joining me, the host is Chidoru Sike, the regional program assistant with SAfAIDS, who's also be leading in terms of the technical side of hosting this session. It's a pleasure to have you joining in this session this afternoon, running under the title, How Can SADC Countries Ensure Reliable Domestic Resourcing of Comprehensive Healthcare Services? So as you might agree with me, the RISDP is quite an exciting entry point as it gives a template or a plan for entry points for SADC member states to address critical issues within the region. So access to healthcare is one of those critical issues within the region. But if we were to do a reflection of where we are coming from, it's been, I think, almost 21 years now from the Abuja Declaration, where member states said, we're going to commit 15% of our national budget towards funding delivery of public health services. And an assessment of that commitment is shown that it has been an uphill task in terms of realizing that 15%. And now when we adopt a number of commitments at the regional level with the SADC SRHR strategy, the RISDP I've spoken about, a critical aspect of success of these plans revolves around how do we create sustainable mechanisms for resourcing delivery of public services. And this continues to affect realization of critical targets. So the purpose of this session this afternoon is for us to reflect as key stakeholders, researchers, academia, civil society. How can we reflect on this conversation and come up with a different narrative that challenges the traditional paradigm? If civil society, do we still go along with the narrative whenever we approach government to say we are recommending or advocating for governments to commit 15%? In an environment where government also is also communicating challenges in terms of actually generation of adequate resources. So my hope and my anticipation is today we're going to have fruitful conversations, but also challenge and come up with a different thought process, different narratives. Do we still talk about the 15%? How about what's already feasible? That is the 10%, that is the 8%, that is the 5%. How can we look at that pie that's already on the table towards ensuring that every citizen is able to access the most basic sexual and reproductive health or HIV service in the region? So that's a brief around what we're anticipating in this session. And we look forward to all your contributions in generating recommendations. But to kickstart, I have a panel of experts who are going to share insights in critical areas that we have to take cognizance of when we're looking at generation of domestic resources. They're going to touch on different topics around use of tax frameworks, public resource management, gender responsive public services, how this can be addressed in a manner that allows us to achieve the end goal. So on the panel today, we have Clayton Fumbunu. Clayton is a technical officer to the Partnership for Social Accountability Alliance, based at the Public Service Accountability Monitor, that is PSAM, at Rhodes University. He holds a PhD in International Relations from the University of KZN and a master's degree in International Relations. And Clayton aspires to influence policy and leadership through evidence-based research. Also on the panel, we're honored to have Johannes Chiminya. He's the Global Tax Advisor with Action Aid, based in Maputo, Mozambique. He has been working on tax justice and domestic resource mobilization issues since 2012 as a research officer for Tax Justice Network Africa, and later as the National Tax Justice Advisor for Action Aid Mozambique. And he's an economist by profession and keen on public finance and economic modeling. Also joining us today is Chengetai Dare, who holds a PhD in economics. He is currently working as a research fellow at the Research Unit on Economics of Accessible Products and the World Health Organization's FCTC Knowledge Hub on Tobacco Taxation and Illicit Trade, that's with the University of Cape Town. He has also prior experience working with the World Bank at the Pretoria office. And finally, but not least, also on the panel, we have Nalucha Ziba, who is the current director of ActionAid Zambia, which is an international NGO. She's an activist and an international development practitioner, bringing in well over 10 years experience in the field of public policy, program development, and implementation, as well as public and global affairs, transnational governance, and she's an adult crusader for women and youth voice and participation leadership and development. Nalucha is a firm believer in putting women and youth at the center of policymaking and development intervention. So you see even from a presentation how we can integrate and prioritize gender responsive public services within the current discourse. So that is our panel for today. Just to know that we are currently recording the session. The feedback from this session will be captured within the post-dialogue product. So we anticipate that we're going to come up with a communique as well as a paper that we're working on generating from the conversations that are going to take place within this session. Then there's a note in the chat box. We are all welcome just to introduce yourself in the chat box. Kindly introduce yourself, stating your name, country, and organization. And we'll also have an opportunity to hear from you after our panelists have also shared their presentations. And for those who prefer Portuguese or French, we have Portuguese and French translation. So you can set it, you can look at your settings and maybe log into the French or Portuguese channels. Thank you so much. So at this juncture, without much ado, I would like to invite our panelists to provide critical insights towards the conversation. I would like to start and invite Dr. Chengetay. Dr. Dare, I would like to present the floor to you and allocated 10 minutes for a presentation. We'll allow for all speakers to present. Thereafter, then we can invite comments, clarifications, questions. So this juncture, I'd like to invite Chengetay Dare. The floor is yours.
Thank you. Thank you so much, Percy. And greetings to everyone here present. And I had a glitch in sharing. I hope you do see my screen from that end, all of us.
Yes, we can see it from this end. I'm not sure if anyone has any challenges. You can just note in the chat box, and Chido can assist.
Okay. So thank you so much. I'll be presenting on how SADC countries ensure reliable domestic resourcing of comprehensive healthcare services. So let me get straight into my presentation by giving you the background. And to start off, let me highlight that the adoption of SADC's Regional Indicative Strategic Development Plan is an important signal and commitment from political leaders that beyond socio-economic problems brought on by COVID-19, there's hope for a more prosperous region. Economic prosperity and health of the population are related. Initial health being an important player in predicting later economic growth. So the success of RISDP, therefore, hinges on a healthy populace. And the public health services, such as vaccinations, are a key determinants of health, but they are highly anchored on the availability of funds, which brings in the conversation that we are actually having on health financing. So to ensure a healthy population, it is important to learn from previous lessons and correct past mistakes, which brings into spotlight the feasibility of the 2001 Abuja Declaration on Health Financing. Now, let me say that it is more than 20 years now since the pledge of spending at least 15% of the national budgets on healthcare was made in Abuja. Yet allocation to the health sector are woefully inadequate. So from this graph, you realize that many countries or many SADC state members have struggled to meet this annual budget allocation. And between 2001 and 2015, SADC member states spend an average of 8.2% of their national budgets on health. And forecasts show that the region's share of public expenditure on health as a proportion of total public expenditure will range between 6.8% and between 6.8% and 12.1% in 2030, which in other ways is just an indication that the 15% target will not be achieved if the region is to maintain the current state of financing health. Now, in rethink the Abuja Declaration, sexual and reproductive health and rights, together with HIV and AIDS, may need to feature more prominently in the debate. Reason being that these two are actually cross-cutting. And now, empirical evidence have shown that these services require modest investment outlays compared to other areas. And investing in sexual and reproductive health is therefore a low-hanging fruit, which in other ways mean that this sub-area may be an affordable target area that reaps exceedingly large benefits. Now, as the deadline for meeting the SDGs beacons, it is important to take stock of the challenges faced by SADC countries in their health financing efforts. Now, one of the challenges that are being faced by SADC member states is limited domestic funds, which is a result of sluggish economic growth, among other host of reasons. And now, external sources, while unsustainable, remain a major component of raising health revenue in SADC. The problem is that the ability of donor countries to sustain current financing levels looks set to decline, especially given the knock-on effects of COVID-19 on the global economy. Even before COVID-19, you realize that there has been a gradual decline in aid flows for health. And the declining aid flows partly account for the funding gaps being experienced in many SADC countries. Now, it has been empirically shown also that the IMF or state measures also have some devastating effect in terms of scattering the efforts by governments to finance health. And the reason being that the conditions by the IMF programs reduce or create budget execution problems for social services. Indeed, the international lender is an ardent proponent of spending cuts for public or social sector services like health to allow countries to honor their financial obligation to the fund. So at the end of the day, if countries are actually obliged to consolidate or to implement some austerity, in other ways, it means that it cannot, it has some threshold within which it is not supposed to exceed on the funding front. And also, we also have another challenge in SADC countries, which is the absence of social health insurance schemes. And the absence of social health insurance schemes in SADC is actually a big challenge. Reason being that although private health insurance schemes, which we normally refer to as medical aids, do exist, high premiums and poverty excludes many low-income households from accessing healthcare services. So in many SADC countries, healthcare is usually driven or financed by out-of-pocket expenditure, in an environment that is characterized by underdeveloped health insurance systems. Now, the problem is that where public health coverage is inadequate or marred by poor service, individuals resort to private healthcare. But this results in health inequalities and it places people in harm's way, since a significant part of the population cannot afford the private medical care. So that is a challenge. And also, like in other many African countries, you realize that the health financing in SADC also suffers from lack of resilience to shocks. For instance, in responding to COVID-19, funds has been had to be diverted from other important programs, such as the Global Fund on AIDS, tuberculosis, and malaria. And this posed a risk of reversal of the decades-long gains achieved in the implementation and treatment of HIV, AIDS, tuberculosis, and malaria, among other diseases. So you also realize that another big challenge in SADC countries is actually lack of accountability and transparency that has created a breeding ground for corruption in health financing in SADC. And corruption in the health financing value chain is a significant risk towards achieving universal health coverage. Annual spending, according to literature, actually on health runs into trillions of US dollars. This is globally. And a significant portion of it leaks out of the system through corruption. In 2014, for instance, you realize that a board of directors for Premier Service Medical Aid Society, a government employee medical aid fund in Zimbabwe, fired its leadership over allegation of embezzlement of public funds to the tune of over $1 million US. And the recent developments in Malawi, South Africa, and Zimbabwe, where political appointees in health portfolios were implicated in irregular, corrupt, and fraudulent practices that undermine healthcare, delivery, also an important indication of the extent and persistence of corruption in the healthcare financing in SADC region. So, last but not least, you also realize that another challenge that we have as SADC member states is the absence of regional or global funds that would support the quick deployment of resources to healthcare areas. So I will expand this in the next slide when I turn this into one of the recommendations. Now, with all these challenges, the question then arises: what is the way forward? And to answer that, I've actually made a list of proposals. And to start off with, let me say that the government in SADC should invest in health. That's key, and it's known.
Hi, Doctor.
Hello.
Sorry, just a quick one. The translator just asked that maybe you can just speak a bit slower so that it also allows as a flow in translation.
Okay. Sorry. I was actually trying to race against my 10 minutes, so I will try and do that.
I offer to you.
So I was saying that with all these challenges, we need to proffer some alternative and sustainable health financing strategies to try and bring ourselves as SADC countries out of these financial challenges. And I think I would propose, I will start by saying that it will be recommended for SADC countries to begin by providing a sustainable framework for generating revenue to fund the sector to address the effects of dwindling external funding. In this regard, I would suggest that governments should consider introducing health taxes to supplement other revenue for the sector. And in this case, I would actually argue to say that taxes on sugar, food, tobacco, and alcohol can provide sustainable revenue to fund the health sector. This will improve revenue generation for the sector, of course. And in this case, raising taxes is also another alternative, which will also improve health by reducing the consumption of unhealthy products. So by raising tax in this case, I'm referring to health excess taxes, which in other countries is referred to as sin taxes. So, and my second proposal will be for government to consider raising domestic revenue and devising some homegrown solution to ensure that the loans from the IMF do not cripple the health sector. And this calls for rearrangement of priorities to ensure that the healthcare is funded at much higher and sustainable levels. And this includes also investments in the sexual and the reproductive health programs. This is particularly important for countries such as Zimbabwe. We do not have too much options regarding accessing budgetary support from international institutions. Then aside from revenue generation, government should consider establishing social health insurance schemes that ensure easy access to healthcare. These insurance schemes may be designed to allow premium payment and tax or government transfers to the scheme. And this will also ensure that ensure adequate coverage for the populace or for the population. And to add to this, it will be important for government to invest its effort in raising awareness of services available to communities, as well as breaking down local and community level barriers, including cultural barriers that hinder people from making decisions that fulfill their sexual and reproductive health and health rights. My other recommendation will be that for government to consider establishing a public-private partnership to fund the healthcare. On this, I would argue that the important role that the private sector can play in the healthy financing or in health financing cannot be overemphasized. In the shift to rely more on domestic resources, especially from the COVID-19 pandemic, governments do not have to go it alone. Governments should put in place mechanisms and incentives that enable the forging of relationships with the private sector in the form of PPPs in order to fund the healthcare. The COVID-19 pandemic, in this case, also provides important lessons where unlikely collaborations between government, researchers, and the pharmaceutical companies have borne fruit through increased availability of vaccines on the global scale. Of course, despite the fact that there are some inequalities in accessing the vaccines. And through these PPPs and other forms of partnership, countries in the SADC region should be able to ramp up healthcare financing. And another suggestion would be for efforts to improve revenue mobilization that are critical is for government to strengthen mechanisms for transparency and accountability. I was actually thinking about the last. So you realize that efforts to improve revenue mobilization are critical, but may miss the intended targets where corruption is rife. Government should more effectively work on curing corruption in the healthcare, both in the public and private sector, and the economy in general. This should be done in seeing with the strengthening mechanisms for transparency and accountability to try and cure the problem of this pandemic of corruption. Now, last but not least, you realize that the global healthcare landscape can be very difficult to navigate for small countries, small in the context of economics. Right. So building on COVID-19 lessons, the SADC region may build a regional health fund that complements efforts towards the regional economic integration. So despite donor fatigue, the SADC regional health fund can leverage debt better, while its bargaining power can also mean that the region has access to medicines and other health supplies at cheaper rates than when individual countries source essential health supplies individually. And such a fund could adopt or can adopt a similar structure to the continent-wide COVAX facility that was set up recently, so that Africa could have better access to COVID-19 vaccines. And with that, I actually thank you for having given me this opportunity to make this presentation. Thank you.
Thank you so much, Chingetedari, for that insightful presentation. One thing I picked from the projection that you shared at the beginning of the presentation is that achievement or attainment of the 15% targets in the long run will continue to prove a challenge. And of course, noting the decline in funding, external funding. But one thing I also found interesting in your recommendations around coming up with a regional health fund, I think this is quite interesting and would like maybe to learn more around how would such a regional health fund look like and what are the implications. But I think this is something that maybe we can converse a bit later. For now, you mentioned the issue around revisiting the tax architecture, looking at the tax architecture. And this is one of the areas that Johannes Chimia is also coming in to expand on. How can we relook around current tax framework and its relation to enabling access to the basic SRH and HIV services in the region? So at this juncture, I would like to invite, if you have any questions for Chingeta, please just note them down. So after this round of presentation, then we'll invite you to respond, to ask any additional questions or seek clarity. At this juncture, I'd like to invite Johannes from AsianAid International to share his insight looking at the role of tax in promoting access to health services. So, Johannes, are you ready?
Sorry, technology was getting the best of me. Thank you. Thank you so much. And good afternoon to everyone. As already introduced, I'm Johannes Chimia, Global Tax Advisor with ActionAid based in Mozambique. I will take you through my quick pointers on how SADC could possibly improve our domestic resource mobilization in order to finance the health service sector, to finance a health service delivery, specifically focusing on sexual and reproductive health rights. Chido, is it possible to beam the slides? Okay, so basically the structure of my short presentation will be, I'll start by analyzing the current financing in general of sexual and reproductive health rights, not only in the SADC region, but also globally. What are the trends? What is happening? Then go forward to analyzing what are the options that have been identified, especially in the RISDP, and are they feasible? Then from there, we look at how we can improve our domestic resource mobilization using taxation. So basically, as already alluded to, we all know this. It's a song we have been singing since 2001. From the Abuja Declaration, our heads of state agreed on 15% of our national budgets being allocated to health, which, however, has been and continues to be a problem. Not many countries are achieving this. And also, there's another question we need to ask ourselves. Is 15% of an elephant equal to 15% of a chicken? If someone has 15% of an elephant, they have a lot. Of a chicken, maybe it's just a thigh, that's it. It will never be enough. So that's why my focus is mainly on having us looking at how we can lobby our governments, discuss with our governments to increase that cake which needs to be allocated, such that even if it's 10 to 15%, which is already what is happening on the ground, it will be 15% of something tangible and could be sufficient to finance our health service delivery. We also have the aspect of donor commitments of 0.7% of GNP. That is what we're looking at in the Abuja Declaration. But you find that basing on donations has not been quite forthcoming. As already alluded to, there's been a gradual decline in aid flows. The donor community has also their own other commitments. We have passed through various crises, the economic crisis of 2008, of 2012, and commitments of the donor countries has been focused on reviving their economies at the expense of our health services sectors here. We also have changing priorities among the donor community, where you find that according to the World Health Organization, the share in the health aid flows that has been committed to sexual and reproductive health rights has been on the decline, from a high of 52% in 2011 down to 42% in 2016-17. And there are many lobbying against sexual and reproductive health rights. And we find that according to the World Health Organization, two large global providers of global family planning services, that is Mary Stopes International and International Planned Parenthood Federation, refused to comply with some policy. That's the Mexican City policy, I think. And this has led to reductions in their incomes, leading to a funding gap of more than 150 million through 2020. So you see, us depending on the outside donors, so to say, will not get us anywhere. We need to find our solutions to improve revenue generation, to finance our own growth and development, as well as to finance the health of our economies and of our economic agents. Talking of COVID-19, we all have seen this. I think for those who have very young children below 2 years, who are still going to get those monthly jabs for polio, whatever, they could actually tell you. I actually experienced this in my home context in Zimbabwe, where you would go to a hospital, and if it's not anything COVID related, sometimes you would be turned back. So the priority has shifted to focus on COVID, but that won't stop us there. We still have options. So according to the RISDP, there are some identified sources. I only touch but on a few, which are domestic revenue mobilization, that's public finance, taxes, official development assistance, which we have already discussed that it's not that reliable. When donor communities' responsibilities change or focus changes, it also affects us as an economy. We also talk of debt, and debt imposes significant costs on our economies through loan repayments, interests, among others. And sometimes debt doesn't just come, as does official development assistance. It comes with conditionalities. We lose our sovereignty in trying to attract ODA and debt. Raising domestic savings, yes, this is ideal, but for our economies at the moment, we have a lot of priorities and development priorities, such that the level of savings which we actually have are meant mainly as to cover for any eventualities which we can't safely say for this year we are cutting 10% of our savings to finance our education. We are not yet in that position because we say we do not have the resources. Foreign direct investment, yes, foreign direct investments makes our economies function and it assists us to raise more tax revenue going forward. However, as we will see later in the discussion, we are actually ending up donating to the foreign investors rather than benefiting from such. Then we'll talk of public-private partnerships. Yes, that's a very good source of investment in resources to finance our investment in health. However, we have to look at it also from the perspective of what is the motive of the PPP? There's a profit motive involved. With the profit motive involved, won't it result in increasing the levels of inequality between the rich and the poor? So basically, going forward, I'm bringing in the idea that we need, as a civil society, as government, and as SADC as a whole, to focus more on how can we improve revenue generation through taxes, because it's predictable. We know very sure that in such and such a time period, we expect to receive X dollars in terms of tax revenues, and we can easily plan. It is also it's predictable and it's sustainable, given that we are raising it on our own. It doesn't come with conditions, and we will be free to do whatever we want with our resources. However, in trying to improve domestic resource mobilization using tax, we find that there are some hindrances to revenue mobilization, which I am just discussing 4 of these. If our time permitted, we would go also to discuss other aspects on how we can improve domestic resource mobilization. But for today, for now, we'll focus on the effect of tax incentives, where actually at SADC level, we have already a SADC MOU on cooperation in tax and related matters, which is covering that, which was developed in 2002, came into force in 2002. We also have aspects around double taxation agreements. And of late, I think most of you are hearing this, that the aspect of illicit financial flows. Then I'll conclude on discussing technological tax, how much we are, sorry, it's the next slide, but you can go two slides down. Yeah, then we talk on the revenue losses from tech tax. So in terms of tax incentives, these are given to attract investors, domestic or international, but in most of our countries, you find that the incentives are being given mostly to multinational corporations to come and invest in our economies. However, these are being abused or overused to result in with a negative implication on our revenue generation potentials. For example, according to the stabilization clauses in extractive tax mining tax in Zimbabwe, platinum royalty is pegged at 2.5%, while other royalties are pegged at 10%, which means just in platinum mining, Zimbabwe is losing up to 7.5% in royalties. And due to this, there was Zimplats took the government to court because the government was not following those stabilization agreements. And due to that, the government of Zimbabwe had to refund up to a total of 101.55 million US dollars in 2015 to Zimplats. If we had just calculated 10% of this amount, in the minimum to our health sector, and it had gone to our health sector. That would be a significant amount, which could actually have helped the health sector of Zimbabwe to improve. We could have some facilities for SRHR to be well administered in the country. We also have other issues such as special mining leases, where the corporate income tax is cut by almost half, from 25% to 15%. And they are build, own, operate, and transfer, and build, operate, and transfer. Those are PPPs, where a company will be levied 15% for 5 years of operation. All this revenue will just be lost. But if we look at it, would Zimplats not invest in the country where the incentives not present? We'll see that below. Malawi also lost around 334 million due to special economic operations in the special economic zones, VAT registration for mining companies, tax holidays of up to 10 years and above, among others. And also, Zambia lost 10.4 million between 2006 and 2012 due to 5-year tax holidays in priority sectors. Who determines the priority sectors? Is those in government, and they would know better what that is. And in the next slide, you find that also these incentives are not all statutory. It's not all the incentives that are found, that are being given to the companies that are found in the tax codes of the countries. Some are statutorily found, some are not. So you would find that, for example, in the extractive sector, in the DRC, incentives in the law are roughly 4, but the companies that are operating in the extractive sector have actually more of incentives. That's the blue bar. On the next slide, please. The example is also clear for Madagascar, who is also a member of SADC, where there are 5 incentives in contracts, while 7 are in the law. You'd find that wherever the blue bar is higher, the incentives in law are lower than the incentives that are actually being given, which means there are a lot of discretionary incentives that are being given. And by giving discretionary incentives, there is a possibility of underhand dealings in order to be given the special favors. So from our perspective, we can lobby for transparency in the issuing of these incentives, such that if an incentive is to be given to a sector, there is no need for bilateral discussions with corporates, as this leads to significant losses. Going forward, we also talk of the issue of double taxation agreements. I have put in an example from Mozambique, where we have signed 9 tax treaties, and withholding taxes in Mozambique are levied at 15%. But you would find, taking an example of the tax treaty with United Arab Emirates, Mozambique is ceding all its taxing rights on withholding tax to United Arab Emirates. They are not charging any withholding tax on dividends, only 5% withholding tax on royalties, no withholding taxes on interest, no withholding taxes on service fees. The only country I have seen in the SADC region which has tax treaties which are giving it at least higher taxing rights is the tax treaties in Tanzania. The rest, we are ceding our taxing rights. By so doing, you would find that Mozambique in 2013, according to ActionAid study in 2015, Mozambique lost up to around 7 billion in tax treaties due to being focusing on companies in Maputo, Beira, Pemba, and Nacala only. This is a picture not for the whole country, but for only those 4 provinces. So you can imagine how much the country lost globally if we are to analyze all these losses for tax treaties one by one. And how it functions, it's simple. Country A wants to invest in country B. Then because there is no incentive to do that, because they want just to minimize their costs, they choose to do treaty shopping. There comes in country C, which charges 0% withholding tax on passive income. Passive income is that income which you are receiving, but you haven't worked really for it. Just like money coming into your account and it goes to another account. You have not worked for that money, but you are just dribbling with it. So they choose to invest in country C, who also has a tax agreement with country B, and with a provision that there are no withholding taxes on passive income, such that at the end of the day, country A benefits now not paying withholding taxes by the investment in country B. And hence, country B is losing on the withholding taxes, who is usually the developing country. We have drafts of the treaties at SADC level, which are sharing the taxing rights equitably. And also, unfortunately, they are not yet in effect. They are not yet being used. We are still relying on the model tax treaties developed by the OECD, which are very old, some dating as back as 1959, like the Macau-Mozambique tax treaty. The operating environment has changed, but still we are making use of that. So there is need to update, and our DTTs making use of the UN tax treaty model, which actually gives also taxing rights to our developing countries. And also we have the ATAF model and our own SADC model treaty, which assist us to have better taxing rights and will assist us to raise better revenue from that. And we also find that, if we proceed to the next slide, as Africa in general, we are a net lender to the global economy. Taking, for example, the data is a bit outdated, but taking it from there, 1970 to 2008, these figures are actually a bit lower than what is currently prevailing. You'd find that aid inflows into Africa ranged between 50 to 80 billion. However, how much was going out of Africa through illicit financial flows? Due to corruption by public officials, we had the issues of Mobutu Sese Seko and the others who were laundering and having assets outside. It was between 15 to 24 billion. Due to criminal proceeds, arms trade, drugs and all, 150 to 80 billion. And due to commercial tax dodging through those financial engineering aspects, making use of double taxation treaties, avoiding taxes using other types of investment, trade misinvoicing and the likes, Africa was losing 300 to 520 billion. So effectively, as we are saying, we will need donor commitments to finance us. Do we really need donor commitments, or we need to reverse this situation and ensure that our resources are not being siphoned out of Africa? At SADC level, according to the Southern Africa Tax and Governance Network, their study which they just concluded recently, you'll find that the SADC region alone lost around 21 billion due to illicit financial flows. according to GFI 2019 data. In the same period, according to OECD, overseas development assistance to SADC region was around 11 billion. So effectively, the SADC region has donated at least $9 billion to the global economy, while we say we do not have enough resources to finance our own development. Oh, 2 slides is down. Yeah, so that's the
1 more minute.
Yeah. So then we also have the aspect of technology tax. Due to COVID-19, almost all of you agree with me, we are working online. And who is benefiting from that? It's the technology companies, right? And due to COVID-19, these technology companies are making a killing. However, our countries are not benefiting because of how the global tax rules are at the moment. You find that in almost all SADC countries, correct me if there's any which is different, we make use of residence-based taxation. By residence-based taxation, we are saying where the company is domiciled, where it's registered officially, that's where they pay their taxes, making all these big companies not liable to pay significantly in our territories. So in 2020, 2021, ActionAid also conducted another study where they focused on 5 companies: Apple, Amazon, Alphabet, Google, and Microsoft, trying to estimate how much tax should have been paid in different countries based on number of users, local tax rates, and GDP weighting, in line with the provisions in the base erosion and profit shifting pillar 1 and pillar 2. And we found that at least G7 countries, group 7 countries, lost up to 32 billion US dollars per year from operations of tech tax companies, with them only being liable to pay their taxes in their home countries. And the next slide. And also focusing now on developing countries who are not members of the Group 7. From our estimates as ActionAid, I will only focus on the 3 SADC countries who are on the table. Tanzania is losing up to 7.2 million annually in tax revenue from operations of the 5 tech tax companies. Zambia is losing 3.5 million. Zimbabwe is losing 2.4 million. If we convert that to the 15%, how much more would we have in our coffers to support health service delivery, as well as to finance sexual and reproductive health rights in our countries? So to conclude, there is real need to focus on a sustainable way of financing our fiscus in SADC through taxation. We need to work on closing the loopholes leading to revenue losses. And one challenge which we have been having as civil society, to speak of, is that there are civil society organizations who are working on service delivery, while there are also civil society organizations focusing on the revenue side of the budget. We need to make a deliberate effort as us in civil society to work together to translate this language of, if we had increased revenue by 2.4 million in Zimbabwe, how much would that translate to in SRH provision in the country? We have the Southern Africa Tax and Governance Network, we have ActionAid, we have Tax Justice Network, among others, who are working on revenue mobilization. their work can only make sense to the politicians if we engage them as partners working on health service delivery. There is need for active participation of a united SADC in the development of international tax rules, principally calling for a UN tax body where everyone has the same footing in determining the tax rules, and also to participate with one voice, like in the current ongoing discussions where the group of 7 is discussing the global minimum tax rate, where they are seeming to move towards 15%. Yet in our regions, we are seeing that with an average of 25 to 32% of corporate income tax, it's not enough to sustain our economies. So unless we play our role as a united front at SADC level, we'll keep on depending on the donors who we are actually donating to through resources they are siphoning from us. And we also need to urgently finalize and implement the use of tax incentives protocols, adopt our model DTA treaty, our own SADC model, as well as finalize on ways to curb illicit financial flows in the SADC region for us to be able to raise enough revenue to finance our fiscus, as well as finance sexual and reproductive health rights provision. Thank you, asante sana, siyabonga mazvita kanimambo, obrigado.
Thank you so much, Johannes, for that detailed presentation. And firstly, when you shared the analogy of 15% of the elephant or 15% of a chicken, as you went deeper, we are left in awe in terms of how much we are losing due to gaps within our tax frameworks within the region. And the example of Mozambique alone, it's really shocking. And how when we close these loops from your presentation, then we can at least improve on the domestic pocket that we can allocate for priority health services. And we also take note of the clarion call to say, let's work together as civil society, those actors promoting access to issues around tax, and those other activists within the sector. Thank you so much for that detailed presentation. I'll invite questions, comments, I think later after the other two speakers, but this was really an eye-opener around how closing tax gaps can contribute towards the right to accessing healthcare services. And building on your presentation at this juncture, I would like to invite Nalucha to speak a bit more, but looking at the perspective of provision of gender-responsive public services. Nalucha, are you ready?
Yes, I am. I had sent through my presentation. It can be beamed from there.
Okay, that is fine. Shilome, you kindly beam the presentation from Nalucha.
Thank you. My name is Nalucha Ngangaziba, and I'm the country director for ActionAid in Zambia. My presentation largely speaks to the issues of gender-responsive public services. We can move to the slides. So number 3. Thank you. So my presentation basically has 3 parts. And the first part looks at gender responsive public health services and inequality in the SADC region. As we have witnessed that the Southern African region is highly characterized by high levels of inequality. There's a huge inequality index in most of the sub-Saharan Africa, but SADC countries rank among the highest. In the 12 SADC countries, the average human development index value is around 0.57 and 0.38 when adjusted for inequality. Therefore, public services are a strong weapon in the fight against economic inequality, especially if gender-sensitive services are to be provided. They mitigate the impact of skewed income distribution and redistribution by putting virtual income into the pockets of the poorest, who are mainly made up of women and men, including young people who are largely excluded from the health service provisions, which the two speakers have spoken to, more especially when it comes to access to primary health care and health insurance. You will find that a lot of women and youth are excluded or are not captured in most countries' healthcare systems, largely due to their vulnerability and living below the poverty datum line. For many living in poverty, access to high quality public services is scarce. We can move to the next slide. And services have the potential, what we have observed is that public health services have the potential to create more equal societies if delivered in an equitable manner. Adequate provision of public services serves women's needs and entails that women will be better able to access economic opportunities and exercise their rights. Among those is also rights to sexual reproductive health and rights, as well as body autonomy. One of those gender responsive public services that are key in bridging the inequality gap are health services, such as sexual reproductive health and rights. Increased access to SRHR can improve women's control over their own bodies, including whether, when, and how many children they intend to have or they want to have. This has a direct impact on the burden of care they must assume in future. Largely, this has been witnessed by a number of studies which we have done as ActionAid when it comes to issues of unpaid care work. You will find that even in most hospitals, even as the COVID pandemic has set in, women have taken more additional unpaid care work. They're the caregivers in most homes and also assisting sick relatives in hospitals on the side beds. And on top of that, they still have to provide, in some instances, they're still the bread earners. Therefore, most of that work still largely remains unaccounted for. Improved neonatal and postnatal services impact women's own health as well as their children's immediate and future health. Comprehensive sexual education directly links reduced numbers of early pregnancies. We can move to the next slide. Therefore, in the SADC region, it has shown considerable progress in the provision of health services, particularly meeting SRHR challenges, as we have seen from the previous speakers, largely due to the large number of donors that are funding SRHR services, as opposed to domestic resources raised in country to meet the health budgets of most SADC countries. The challenge is still huge and needs to be prioritized to advance social and economic development in the region. We have also witnessed sexually transmitted infections as too significant a public health challenge, not only in the SADC region, but the world at large. The World Health Organization Sector Strategy on Sexually Transmitted Infections 2016 to 2021 indicates that syphilis in pregnancy leads to over 300,000 fetal and neonatal deaths globally each year. Also, the human papillomia virus, which infection, which causes cancer, an estimated 530,000 cases of cervical cancer and 264,000 cervical cancer deaths every year. Maternal mortality ratio is still high in some SADC countries. For example, in DRC, their maternal mortality rate is 846 per 1,000 live births. Zimbabwe has 651 per 1,000 live births, with a lifetime risk of maternal death estimated as in 1 in 37 women dying from pregnancy or childbearing. We can move on to the next slide. Public health services are not only inadequate, but they are also underfinanced, and thus, instead of bridging the gap of inequality, they have tend to reproduce structures that widen inequality. We can move to the next slide. An example I'll give is of Zambia. This is the budget allocation to the health sector in Zambia. So it shows a trends period from 2010 to 2021. You will see that the budgetary allocation was going up between 2012 and 2013, and 2014 onwards, it went on decreasing. And we saw a slight improvement in 2018, 2019, going to around 9.46%. And we have seen a downward decrease in 2021 at 8.07%. So you realize that this picture, it's not only speaking to Zambia, but quite a number of countries in the SADC region. Okay, I'll slow down. It's speaking to a picture in a number of countries in the SADC region, largely due to issues of debt servicing. We can move on to the next slide. The underfunding has been due to, among other things, low or no domestic investments due to low tax revenues and high and unsustainable levels of external debt. For instance, for the government of Zambia, they are servicing around 51% of the national budget is going towards debt servicing, which is getting a larger chunk of the national budget than public service provision. And I believe this is what this graph here is showing: debt servicing versus health budgetary allocation as a share of the national budget for Zambia. So you realize that the debt service delivery is on the increase, while funds meant for delivery of public health services, such as health itself, are on the decline. And we'll continue witnessing this as a number of SADC countries are into debt distress, Zambia being one of them, I believe Angola being one of them, Mozambique, and Zimbabwe. We can move on to the next slide. So most SADC countries, Zambia, Zimbabwe, Mozambique, Angola, just to mention a few, are grappling with unsustainable public debt, which is defeating the sole purpose of enhancing domestic resource mobilization through taxes to finance public services, as provision of most of the resources generated are going towards debt servicing at the expense of public service financing. We can move to the next slide. And we saw that from the presentation that Johannes gave in terms of opportunities and areas for domestic resource mobilization through taxation. The underfinancing of the health services, among other public services, due to low tax revenues, calls for the need to rethink on the financing for public service provision. There is need to interrogate the wider economic forces determining the underfinancing of public service provision. There is also need to appreciate the power of tax in financing gender-responsive public services. A gender-responsive public service can only be sought and offer greatest possible access for the people who need them if they are publicly financed through taxes. And the reason why we are emphasizing on taxes is because of their predictability and also just their generally availability within the country's economies. It is unfortunate to note that most SADC countries are still experiencing problems associated with grafted capitalism, as we depend on donors or external financing to meet at least 30 to 50% of our annual budgets. We can move to the next slide. For some time now, there has been a realization to shift from this to domestic resource mobilization to finance our development and public service provision. This harnesses the risk of privatization of public service delivery, which may be prohibitive, as well as raise concerns on equity and leaving many behind. As we have seen, learning from other jurisdictions such as West Africa, Liberia, and others, where we have witnessed privatization of key public services such as education into private hands, therefore leaving out the poor. This also reduces government over-reliance on external financing and resorting to over-borrowing to finance the sustainable development goals and provisions of public service delivery. Also, what we have witnessed with the high debt servicing is that in most countries where it's happening, Zambia as an example, we have seen the crowding out of the local SMEs from the markets in terms of borrowing and lending, as government is now the major player on the market. Thereby, there's very little liquidity in the economy. Therefore, even as we are advocating for more taxes, such as health taxes, to be introduced, we also have to bear in mind the other factors that are playing in these economies, more especially in the SADC region, those with who have got higher debt service obligations. Domestic resource mobilization in the SADC region and Africa at large has, however, hampered the systematic challenges of domestic resource mobilization through taxes, which includes illicit financial flows, offshore tax avoidance, and evasion by wealth individuals and multinational companies, as well as regressive tax incentives, such as unbalanced double taxation agreements, mispricing, resulting to Africa losing over 15 million annually. This is an old figure, which will need to be updated once new studies are undertaken. But also just to mention that also what we are witnessing now with the high debt servicing, a number of countries have also gone back to start renegotiating their double taxation agreements, others canceling, like we saw the issue with Zambia, where their double taxation agreement with Mauritius was recently cancelled in an effort to try and get more taxes from the double taxation agreements. We can move to the next slide. It is also worth noting that there has been generally an increase in the government revenue to GDP ratio in the recent years in the SADC region to an average of 15 to 20%. This has been driven by the improved performance of non-tax revenues, as well as personal income tax, as the expense of corporate taxes, which has been going into the opposite direction. There is need, therefore, to recommit or enhance the commitment to domestic resource mobilization through taxes. There is need for SADC countries to have a consolidated and holistic effort to fight illicit financial flows by reviewing and enacting legislation, providing for pursuing of cross-border financial crimes, facilitate regional review of regressive tax treaties, promote and enhance regional information sharing architecture to mitigate illicit financial flows, related information asymmetry, among others. We can move to the next slide. As I end, gender responsive public services are only so if they are financed publicly through taxes, and also a primary means of providing publicly funded services to enhance domestic resource mobilization, adopting a full range of progressive taxation measures so those who have more pay more and those who have less pay less. When progressive taxation is not in place, people living in poverty suffer from tax legislation favoring rich people over poor people. Also, efficient and progressive taxation could improve the government's revenue position, reduce public sector borrowing, reduce dependency on aid, and increase SADC countries' ownership of their developmental agenda, and more importantly, provision of public services. Thank you.
Thank you so much, Nalucha. This is highly appreciated. And I think from the presentation, one of the aspects that we've got is the importance around ensuring equity in access to health and creating equal opportunities, that all health needs are addressed for women, men, young people. And critically, something that continues to come up again, the issue around illicit financial flows and how these are compromising public investment in healthcare. And speaking on from the presentation from Johannes, I think the issue for civil society is around how do we collaborate and create a wider movement pushing for the governments to take more deeper steps in addressing or stemming illicit financial flows. Thank you so much, Nalucha. We really appreciate. I'll invite the participants to also share questions for clarity after the final presentation. At this juncture, we're running a bit behind time. My sincere apologies. We hope we'll just stick to the 10 minutes. I'd like to invite the final speaker, last but not least, Clayton Fumbunu with PISAM, Rhodes University, to speak around public resource management. Over to you, Clayton.
Thanks very much, Percy. I don't know whether you can hear me, and also I don't know whether you can see my presentation, which I've just shared.
Yes, I can hear you, and I can see your presentation.
Wonderful. Okay, thanks very much, colleagues. And for those who came in a bit late, my name is Clayton. I'm based at PSAM here. I work for the PSA Alliance project, the public service. I'm in the Partnership for Social Accountability and Alliance, but I'm based here at PSAM at Rose University. So I will be presenting on strengthening management of public resources for better SRH outcomes. So what my presentation will do is that from what I've just checked from the presentation that we've heard from Chengetai, from Joannis, and also from Nalucha, my presentation is building on this and also complementing what they've just presented. But of course, I'm more focused on the angle of how we can strengthen the public resource management systems for better delivery of sexual and reproductive health services. I'll try to make it in time, and also I'll try not to rush too much so that I'm fair to our translators. Okay.
Clayton, so
yes, Alan.
Just put it on slideshow so that we can see it clearly.
Okay, let me do that. Mm-hmm. It's showing, right?
Yes.
Okay, thank you very much. Okay, let me continue then. Okay, what I tried to do was try to first locate SRHR services within the SRHR strategy of SADC region, and also try to locate that strategy within the RISDP plan itself. So what we'll see that the good thing about the strategy is that it's covering the entire period upon which the RISDP is going to be implemented. And it's very then easy for member countries to localize this. And the most important thing then is to then think about how best can we make sure that at least member states of SADC can be able to manage and to manage well the resources that are allocated for SRH services in a way that ensures that at least we can achieve the outcomes of our SRHR strategies. Okay, so that's the vision of our SRH strategy. But basically, my focus should more on what is it that we seek to achieve. It's more integrated services, reduced mortality, maternal and newborn, that is, then reduced infections, issues to do with GBV that Nalucha was talking about, and also rates of unplanned pregnancies, teenage pregnancies, and safe abortions, and issues to do with strengthening community health systems and enabling environment for adolescents and young people. But I want us to look at what have member states done in trying to make sure that at least they achieve SRHR outcomes. They have deployed policies, laws, strategies, and resources. But my focus is more on resources to say that though these have been deployed, it does not necessarily mean that SRHR outcomes then are guaranteed. The most important thing then is how do we ensure that there is more efficiency, effectiveness, and economy in the management of these resources that are dedicated for SRHR services. Now, we have been talking about this, the 15% that is supposed to be allocated to health. I think Joannis talked about it when he gave his analogy. And I also give my way to that. I think we know that there has been a lot of lobbying. It's good, but it has its own challenges by sector-specific, CSOs. If you go to education, if you go to agriculture, they talk of the 10% Maputo Declaration, that 10% is supposed to be allocated to agriculture. And as we speak, the global campaign for education and also the African Network campaign for education, they are saying we are supposed to also, they are lobbying the African Union, in fact, to make a declaration that says we are supposed to allocate 20% of national budgets to education. Already these three sectors would chew 45% of our national budgets. And I know sector-specific CSOs like those for water and sanitation will also say we need a specific percentage. And before you know it, half of the percentage has gone to 4 sectors. But to me, I think more emphasis should be on how best do we make sure that what has been allocated is managed in a way that it delivers. If we check what has been allocated by our SADC countries, in even African countries, in terms of the percentage to GDP, the World Bank, I mean, it was using data from the WHO, was saying that the average sub-Saharan African countries were, on average, they were allocating about 5.8% of I mean, health budgets were constituting 5.08% of their budget to health. This is higher, of course, compared to Asia. The health budgets constitute 3.48 of their GDPs. And the Middle East and the MENA countries, the Middle East and North African countries, they were higher with 5.96. And EU, of course, is almost 10%. But again, like I indicated, this is not guaranteeing the delivery of what we intend in terms of health sector delivery of services. Now, I've just shown this on the graph. It's the same like I was presenting. The point then is to say, is it just about getting the resources? It is not, like I was indicating. So my presentation is going to build on a number of evidence that we collected through community scorecards of assessment of about 5 countries in the region. That is Malawi, Mozambique, Zambia, Zimbabwe, and Tanzania. But it's also going to make use of some findings that came from Supreme Audit institutions of the countries, that is their Auditor General's reports, on how the resources have been utilized and managed in the health sector. And also it's going to make use of several reports to say how best and what are the PRM challenges that we are facing in the region, and also how can these be managed. But in trying to organize my presentation, I tried to use the framework that we use here at PISM that focus on the 5 interlinked processes of public resource management in the public sector. That is planning and resource allocation, performance management, expenditure management, and public integrity management and oversight. Basically is to say, what are the systemic public resource management challenges or failures across these processes, and how can these be addressed to ensure that at least they can be better SRHR outcomes. So, like I was indicating, the question then is to say, what are these challenges that we are facing in public resource management in the health sector in SADC member states? We can generalize the 5 country focus to other countries because we more or less face generic challenges in the sector in terms of public resource management. Okay. So the first process of budgeting, planning, and resource allocation. It is in this process that a number of SADC countries are facing challenges in terms of limited consultation of citizens and having the priorities and needs of the citizens considered in terms of resource allocation. There are also challenges that citizens are facing in terms of not having the opportunity to interrogate the plans within the health sector, and also to scrutinize a lack of information that is enough for them to scrutinize the strategic plans and budgets and choices that are made in the sector. There are also challenges relating to fiscal transparency, that most of the time you find that they do not have much information in the public domain for also the citizens to be able to scrutinize what has happened in the previous financial or fiscal year so that they can inform their choices and decisions. And also issues to do with all these have been captured on various indices, like I was citing the Open Budget Survey, which is published by the International Budget Partnership, which assesses the extent to which citizens are able to access information from their governments in terms of what is raised as revenue and what is spent. So I just selected SADC countries there. We can see how the Open Budget Survey Index is ranking the countries for 2019. The countries that give extensive information, they get scores from 81 to 100. And we see it's only South Africa that is there, which is providing extensive information. And most of the countries in the region, they are just providing limited information, as you see, that we have from Madagascar, Mozambique, Zimbabwe, Namibia, or they are providing what is termed limited information. Otherwise, most of them, they are providing minimal information, like we find from 21 to 40 that is being provided. And of course, the good thing about it is there is no country that is qualifying as providing scanned information. But there is room to improve in terms of providing information. We are saying this information that they talk about, it has to do with budgets, information on the budgeting process, the content of the budget, and also bring it up there to the public domain for them, for the citizens to interrogate so that they can be able to make decisions. Now, when it comes to expenditure management process, again, the challenges that we are identifying through our community scorecards and also reports from Supreme Audit Institutions and other reports are that the ministries of health or the health facilities and hospitals and even local authorities that are in charge of some health functions, they more often than not, they are spending outside their means. They are not spending within their means. And there are also cases where they are spending on issues or things that are not identified by citizens as priorities or needs. And there are also instances where there are a lot of wastages of resources. And the reports, like I was indicating from Supreme Audit institutions across the countries, they are showing that there are a lot of breaches of resource usage or expenditures that are outside the stipulated processes through the existing legal framework, especially the Public Finance Management Act, which guides how resources are spent within ministries. And also revenues and expenditures, there is mismanagement there. Then internal controls, or most of them, you find that they are lacking or they are weak, and like there are no risk assessments, and there are no audit committees that are doing their work, and payment procedures are not followed, and there are issues to do with under expenditure, and of course, over and above the over expenditure that we talked about. So these are some of the issues that are coming out of expenditure. But I'll give snippets to give credence to these. It's not just claims. They are, I think we are familiar with, this has been over-publicized, the issue of the Malawi investigative report on the usage of and the accountability of the 6.2 billion kwacha COVID disbursements. There were a lot of issues that came out of that. And these include the wasteful and ineligible expenditure that was amounting to about over 40 million kwacha. Then there were also accountability related challenges where you could see the expenditures that are missing and there are no receipts to that, which were over 39 million. And also irregularities relating to procurement. At times, some of the prices were inflated and there were no bidding documents that were produced, and there were irregularities in terms of procurement, which was over almost 500 million, which was lost through that. Diversions also came out of that report, and also abuse of allowances, where we have overpayments, irregularities, and some officials who were paid even when they were in their duty stations and so forth. All these, they compromise, of course, the delivery of health services and inclusive of SRH services. So this is a case of Malawi through the audit that came out. And also another case is that of Tanzania, where if you look at their 2020 year-end budget, which was presented this year in March, that in the Ministry of Health, there were over 257 million shillings amounting to unbudgeted payments, and some expenditures were not authorized by the ministry, meaning to say they had to just go without any authorization, and they were almost 43 million to that extent. So these are some of the cases where expenditure management itself has challenges as part of challenges that we find in terms of PRM failures around the process. These are some of the collection of some of the reports that came out in terms of the reaction that came mostly through the audits, what would happen. Some were knee-jerk and ad hoc, but we would see a lot of heads rolling. Malawi did it, and also in Zimbabwe. And in Zambia also, they were reported, firing of certain individuals, but of course, with the decisions later reconsidered after we heard that some of the evidence was not sticking. But the point is to say that in terms of expenditure management, there are a lot of PRM challenges that are faced, and a lot of resources being lost in the process, to the extent that if we consider how much this is and what impact it would make in the health sector, one would then think to say, look, maybe there is more that needs to be done in terms of how we can strengthen the PRM processes. And also, there was the case of budgeted funds that are never released or they are delayed in terms of disbursement, and some expenditures are not supported in the health sector. There is a snippet that I'm sharing there from the auditor reports for Zimbabwe for the year ending 2019, which was presented again to the parliament this year in April. In the ministry, it was noted that about 155 million was set for implementation of key programs, including the procurement of ambulances, provision of water in some hospitals, and also equipment, medical equipment. However,
sorry, Peter, one more minute.
Okay. Hello, Percy.
Please proceed. I'm just saying we're running out of time.
Okay, let me quickly do that. Then I was just given an amount to say, of this, only 1% was utilized of the amount that was allocated for all this. And of course, there are reasons that are given to this underutilization of funds, like non-release of funds and so forth and so forth. I was also about to give the example of 11 public health institutions also that were audited, and we had the challenge of all this money not having the source documents, requisitions, invoices, and vouchers to support it. I'll rush because of time, but I wanted also to give this as part of all this most of it amounts to corruption, and also to say this is how the countries are ranking even on the corruption perception index. No movement, and most of them, I mean, the ranking of corruption perception index is that 0 is for those countries that are showing that at least they are very corrupt, and the opposite is they are clean. So most countries in the region, they are not ranking so well on that. I'll quickly go to performance management. Again, the issues that we are facing in terms of public resource management are lack of efficiency and effectiveness in the utilization of resources, and at times targets are not met and there are no explanations. Performance reporting systems are not so good, and internal controls, like I indicated, they are lacking, and there is poor risk management and also not effective strategies to improve health service delivery. From the CSC surveys that we did, it emerged that the quality of services themselves are being compromised at most health centers, lack of staff, understaffing, and also the hiring of non-qualified or even volunteers to do the work, and at times the issues to do with how they relate to the public. But still on this, the audit reports from the different countries, like I gave Zimbabwe there and Tanzania, they are showing that there are challenges relating to performance management. Like an example of a hospital, it came from the audit report of Zimbabwe, that there is a hospital there that just gave a verbal contract to a subcontracting company for mortuary services. There are no performance targets there that we would know for us to measure that, and we don't know the the conditions set for that. So it's very difficult, for the public then to be able to do their work in terms of accountability, which affects even the way resources are being used. I will not go much into that example of the Tanzanian case, where procurement of security and consultant services in the Ministry of Health, and there were challenges relating to compliance with the procurement regulations. But on public integrity, the most challenging issue that you find is that there are rampant cases of breaches of frameworks, in internal controls, laws, and also regulations that are put in place for the processes like financial management, payments, and procurement. But nothing much is being done in terms of following up on these people that are breaching these, which then means that there is no incentive to prevent or to avoid by the office holders. Then itself is a big challenge. I'm just giving an example of cases in Zambia, for instance. The 2018 audit was giving that there are some officials, of course, who had issues to do with getting funds, yet they were now outside, not serving at the station that they were in the health ministries and departments, but no corrective measures were taken. Even those who were abusing allowances, nothing has been done to them in terms of disciplinary processes. It's solved a challenge in terms of continuation of these challenges. But the last process is on oversight. Oversight, we know, is provided mostly by Parliament and also the Supreme Audit institutions and other committees. The challenge we are having there is that at times there is a lot of politicization of accountability, to the extent that the executive itself, the ministries of health, at times they may not avail themselves for questioning or even to take action to correct issues that are found to be on the wrong side of the law. So I will quickly then say, after all this, if you look at all the processes, that is from resource allocation and planning and performance management, public integrity management, oversight and expenditure management, there is a challenge that a lot of resources are being drained through mismanagement, and there is not much accountability to this. And in the end, we cry for more resources in terms of what we would expect from the national cake, but the challenge has been mostly on how we can best utilize the resources that we have. But what are my recommendations quickly? I think the best way forward might also be considering advocating for more emphasis on effective and efficient utilization of public resources, as we do our advocacy as state actors and working government, of course, there should be frugality in the use of the available resources. Member states also may need to avail more information to the public, which is PRM related, so that at least citizens can be able to be more informed and hold those responsible for management of resources accountable, and also make informed decisions in terms of articulating what they need and what they feel are priorities. The second from last, we can see from the systemic PRM failures and challenges that the challenge is mainly to do with ineffective social accountability systems. But how best can this be addressed? The best way may be to deepen engagements between non-state actors across the board, so that at least there can be more engagement with office holders to ensure better outcomes in terms of SRHR. Then lastly, the oversight function in mind, there is need for parliaments and of course the CSOs to intensify efforts and strategies, of course, to ensure that at least what has been discovered and detected in these audit reports do not just remain recommendations and are forgotten, like what is happening most of the time, but there is supposed to be some follow-up mechanism and dashboards to ensure that at least whatever has been reported, there is follow-up and recovery of lost resources, and also most importantly, prevention of the same in the future. With this, I thank you so much.
Thank you so much, Clayton, for that insightful presentation. And I liked how you started and spoke about how the education sector is advocating for certain budget allocation, agricultural sector is advocating for certain budget allocation. And now ultimately, this might not be feasible or have barriers in the short to medium term, and how we need to improve and focus on what is the current cake that's available, ensure economy, efficiency, and effectiveness in the management of the resources that are already there. At this juncture, my apologies, we're not doing well on time. I'd like to invite if we can have a maximum of 3 questions or reactions to the presentations, so that we can also wrap up. We are just preparing for the closing ceremony of the dialogue. So my apologies for that limitation in terms of time. I'm seeing in the chat box, there's a question headed to Johannes. It says there are very few SADC countries in the common reporting strategy. From a civic society or NGO perspective, what can be done to push more countries to join? So that question is directed to Johannes. Any other questions? Feel free to raise your hand or input in the chat box. So in the meantime, maybe Johannes, you want to take that question on while we check if there are other questions? Hello, Johannes. Fortunately, I'm not picking a response. Maybe I'm having challenges. Any other comments, reactions, questions?
Hello.
Hello, hi, Johannes. Sorry, there's a question in the chat box for you. Maybe you want to just respond to it?
Well, I will respond to this basing on my other experience, which I have had working on the African Charter on Democracy, Elections and Governance. I think the response will be more or less the same, that in as much as some strategies are developed at SADC level with all countries involved, you'd find that when it comes to its implementation at national level, the staff in government who are supposed to be doing that do not have sufficient information on it. This is what we saw with the African Charter on Democracy, Elections and Governance. And the idea would be, as civil society, we take it upon ourselves. We have identified this challenge that most countries are not there. We try to capacitate them on what really is the common reporting strategy. How beneficial is it to us as countries and to the citizens? Then from there, we can start getting, through direct engagements, we can start to realize now more countries opening up on it and starting to re-engage. This is the long and short of it. But maybe if there is need for a detailed response on that, maybe I can put it in writing and share.
Okay, thank you so much, Johannes. I hope, Chengeta, your question has been answered. Anyone with a burning question, a reaction to the presentations? To the first presenter, that should be Chengeta. There's a question for you in the chat box. It says, won't introducing health cases lead to more health gaps? Amazing people. Won't introducing health taxes lead to more health gaps? Amazing people, regardless of the boost it will give to the health system. And how can SADC countries run from this? I think the questions around the impact of increasing taxes. So I guess this one is directed to Chingetai. The impact of increasing or introducing health tax.
Sorry, Percy, I didn't get the first part of the question. I got the second part.
It says, won't introducing health taxes lead to more health gaps? There's a certain question element missing, but that's the overall question I'm getting. And also the impact on people, if we're increasing taxes, the impact on the population as well. So that's the question. One impact.
Let me start off with the last one, which I got clearly well, and attempt to answer the first part at a later stage. So by increasing excess tax, you realize that excess tax by nature, they are price inelastic. By price inelastic, we are saying that they don't respond to changes in prices. So what then that means is that, okay, before I say that, the other point is that apart from being price inelastic, excess tax are actually levied on goods that do harm our health. So by nature, those goods will actually pose a cost on our health and also add burden to the fiscus by virtue of creating a cost on health. So by increasing excess tax, in other words, the government will be saying that you need to reduce on the consumption of those goods. And because those goods are price inelastic, you realize that there will be a very minimal change in terms of consumption or demand for those goods. But at the same time, you realize that because of an increase in excess tax, the government will actually be raising a lot of revenue. So in other words, it is normally referred to as a win-win tool of raising revenue. Win-win in the sense that it benefits the government, win-win in the sense that it also benefits the consumers because it actually saves costs on their part as well in terms of expenses on health. So that is actually a positive thing to increase excess taxes on goods that do harm our bodies. And the first part, if I got it correctly, was regarding the gaps, financing gaps, I think, or tax gaps, something like that.
Won't it lead to more health gaps among the people by increasing taxes?
What?
In the chat box from Tokozile Lungu, it says, won't it lead to more health gaps among the people? That's the question, increasing taxes.
I don't think so, because in this case, the people who will be affected are the consumers of those scenic goods, so to say. The scenic goods are goods that pose the health risks on our bodies. So by increasing taxes, they are actually saving the consumers of those goods. So it's actually a very good strategy. And if you are to look at literature, you actually realize that most countries that do actually raise those taxes more often times. Like in this case, okay, more often times they do raise a lot of revenue. Like in this case, if you are to check at excess tax for tobacco, for instance, the World Health Organization is actually advocating for government to raise that to at least 70% of the retail price. That is a recommendation. And most countries are actually below 40%. So that is actually a positive move to take, and it's actually a very effective tool in terms of raising finance for health. I hope I've answered the question well.
All right, thank you so much. Yes, Tokozile is acknowledged. Thank you, Toko. Then finally, the last question, I'll see the hand up from Adam Judas Piri. The floor is yours. Hello, I'm seeing your hand is up. Adam Judas Piri. Do you want to raise your question?
Yes, hello, good afternoon.
Afternoon, the floor is yours.
Hello, good afternoon.
Yes, we can hear you.
I think yes, we cannot leave our health in the hands of others. We depend on the donors for our health. But my biggest worry that I have is
Hello, Ad. So I think we're losing you. Are you able to type in the chat box? Able to type in the chat box? Then I'm seeing a comment from Susan Kamuti. Thank you, Susan. Most countries in the region have legislature that guide public resource management, but we see a situation of corruption worsening in most countries. What sort of measures can be influenced to see significant decrease? I think this is a question around how can we get corruption? So this is question I think I'm thinking is just for the speakers. How can we address issues of corruption? I think Nalucha spoke to the issues of illicit financial flows. Similarly with Clayton around how corruption is affecting health funding. So I'll just put this to the panelists and then we can wrap up from here. Thank you so much. From our panelists, anyone wants to take a shot at the question or to start question around corruption and how can we address this despite the existence of legislation?
Hi, Percy.
Hi, Clayton.
Yeah, I will just quickly respond to Susan's question, then others will come in. It basically says that we do have the legislatures or the parliaments that guide PRM, but how come we still have corruption? That's the question that she's asking. My response is very simple. I think the challenge that we are having is that it should not be left to the legislatures alone, but it should be everyone's responsibility, from citizens, from CSOs, and from all concerned people in the body politic. So what needs to happen is basically to say the laws that are there are supposed to be implemented, but the government has to be lobbied to do that. So what citizens need to do is to work together, and CSOs need to work together and make sure that at least they bring these issues before. The challenge we have is that we are having audit reports that are exposing a lot of ills in terms of PRM. And these issues, they are forgotten once the new audit report comes, and the new audit comes, then another one comes, and it goes on like that. What citizens and CSOs need to do is to place more emphasis on pushing the government to be able to act on all this before we even talk about any other new reports that are coming in. So it's everybody's responsibility, and CSOs working together to lobby the government and working also with the parliament to make sure that at least there is follow-up on all these exposed issues in terms of PRM across the health department and other departments.
Thank you, Clayton. Anyone else from our panelists want to respond? The issue around corruption, how can we stem and linking it to issues around illicit financial flows?
Yeah.
Yes. Please go ahead.
Okay, thank you. Yeah, so I actually am in support of the position or the points that have been raised by Clayton, where citizens have to play a role. But in this case, I may perhaps need to implore also the civil societies to conscientize the masses to actually know their duties as citizens. Because up until citizens hold those in authorities to account, obviously nothing will change. So that is my further point to Clayton's. And with specific reference to illicit financial flows, I actually would suggest that perhaps it is actually an opportune time for civic organizations to also push for SADC countries in particular to also join the common reporting strategy. And for the benefits of most of us, the common reporting strategy is actually a strategy where tax authorities are required to gather information from financial intermediaries from within their jurisdictions and exchange the same information with other authorities across the globe on an annual basis or upon a request. So this strategy was put in place to put an end to an era of banking secrets in tax matters. But you will realize that most governments, most countries in Africa and in SADC in particular, are actually not part of it. And the question is why? And my suspicion is that they are actually the very people who are actually benefiting from this illicit financial flows. So obviously they wouldn't want to unmask themselves. And I would suggest that it is also a duty of the civic organization, in this case, not of the citizens, because a lot of citizens are actually not aware of this, of the existence of the CRS. So I would also implore the civic organization to try and push our governments to also join this platform so as to try and deal with this rampant corruption. Thank you.
All right, thank you so much. So at this juncture, I would like just to wrap up and say special thank you to our panelists, Johannes Chiminya, Clayton, Nalusha. Thank you so much. And Dr. Dare, thank you so much. We really appreciate the insights from your presentation. And for all those who have joined, thank you so much. I sincerely hope that the conversations have been quite beneficial in terms of learning. In terms of the next steps, we're going to find the conversations into a communique that we hope to use as an advocacy tool targeting SADC member states as we look at the launching or rollout of the RISDP and other regional commitments. So this leaves me to say thank you, wishing you a fruitful rest of the day, and hope you also be able to join in the closing session for this particular dialogue. I'd like to declare our session officially closed. Thank you so much.
Thank you. Yes.
Thank you so much.
Welcome. Okay. Okay, bye everyone.
Thank you and bye.
Thank you, bye.